Welcome to Module 4. We will now talk about somatic and dissociative disorders. Our focus will be on Chapter 29. What is somatization? It is an expression of stress when there is no underlying diagnosis, but clients really feel sick. Historically, somatic symptom disorders were considered hysteria or hysterical neurosis. Approximately 4,000 years ago in Egypt, hysteria referred to a condition of emotional excitability that impacted psychological, sensory, vasomotor, and visceral functions. It was characterized by being wildly emotional with uncontrolled excitement and laughing. It was thought to be caused by witchcraft. Somatic symptom disorder, SSD. Clients have multiple somatic, vague, and often dramatized symptoms with no medical diagnosis or organic pathology. Clients can become dependent as their focus is mainly on their unreal symptoms. Some of the common symptoms are chest pain, abdominal pain, dyspnea, headache, back pain, etc. Symptoms begin before age 30. Let's do a quick recap. How does SSD present? Somatization is the expression of psychological stress through physical manifestations, not an underlying medical pathology. Clients frequently visit many doctors seeking assistance, and they are preoccupied with symptoms and oneself. Some symptoms they are obsessed with include abdominal pain, back pain, pain in extremities and joints, menstrual cramp problems, headaches, chest pain, heart palpitations, dizziness, fainting, dyspnea, illness anxiety disorder, hypochondriasis. It is an obsession with the idea or fear of having a severe illness, or being seriously sick, conscious of body sensations and changes. These clients also have a history or obsession with doctor shopping. May be misinterpreting symptoms. Conversion disorder. A functional neurological symptom disease. It implies a loss of or change in body or motor function that cannot be explained by any known medical disorder. Here is a visual of how clients feel when they have conversion disorder. It is as if there is perfect communication and coordination between the brain and spinal cord with no organic symptoms of illness. However, the client complains of several symptoms affecting their motor function. Symptoms like blindness, paralysis, pain, seizures, gait disorders, hearing loss. Affect voluntary motor or sensory functioning, suggestive of neurological disease. How can we help clients deal with conversion disorder symptoms? We should treat them as real, till the doctor mentions otherwise. Factitious disorder, Munchausen syndrome. Reporting untrue symptoms to seek attention, avoiding responsibility, or causing self-injury. When it is imposed on another person, usually a vulnerable child or adult, it is known as factitious disorder by proxy, or imposed on another. What are some nursing interventions for a client who presents with SSD? Accept the symptoms as real. Assess for suicidal ideation, report any new physical symptoms to the doctor. Do not focus on discussing symptoms with the client. Encourage self-care. Medications can be given as for any real symptoms other clients usually present with. Also, labs and imaging can be ordered. Dissociative disorders. These are disruptions in the brain or consciousness, which can even affect individual identity. They may be due to excessive anxiety leading to compromised personality. Clients are likely to experience relapse after 1 year. Therefore, a follow-up is recommended. A. Dissociative amnesia. Partial or total memory loss, with inability to remember important personal information usually due to psychosocial stress, wars or disasters. Amnesia can be caused by medical conditions like seizures, strokes or tumors. Dissociative amnesia stems from emotional trauma and is often temporary. One specific type of dissociative amnesia is known as dissociative fugue. Clients travel away from their home and wander purposelessly, may change their ID, and cannot remember their past or how they got to the new location. B. Dissociative identity disorder, also known as multiple personality disorder, having multiple personalities alter identities in one individual, may be due to stress, sexual or physical trauma/abuse. Clients with dissociative identity disorder have a hard time remembering their childhood. They can experience hallucinations and flashbacks. They may have interference in their social and occupational functioning and display suicidal ideation. The disorder can be confused with depression or borderline personality disorder. Depersonalization-derealization disorder. Detachment from one's self-awareness, body, or image is referred to as depersonalization, while a detachment or distorted perception of the external environment is known as derealization. The disorder is temporary, and clients, usually with comorbidities, such as schizophrenia, depression, and panic-level anxiety, feel like going insane, floating outside one's body. Clients also feel anxious and have somatic and obsessive thoughts. Dissociative disorders may be due to genetic, neurobiological factors, or psychological trauma. For example, physical or sexual abuse by a close family member. Dissociative identity disorder is thought of as a survival strategy from past abuse or trauma. Treatment modalities for dissociative disorders, such as dissociative identity disorder, consist of individual psychotherapy, CBT, group therapy, medications, hypnosis, and supportive care. The outcomes for clients consist of helping them to gradually cope with symptoms they report, such as past trauma and memories. We want to enable them to verbalize anxiety due to dissociative disorders. Also encourage them to integrate personalities into one, especially for dissociative identity disorder, and maintain a sense of reality. Thank you for reviewing the most common somatic and dissociative disorders. Enjoy the rest of the week. Watch out for more simplified presentations of fascinating yet challenging psychiatric disorders.